Is my screen visible?
Yes.
Okay. Good evening, everyone. Many thanks to the organizers and special thanks to Ambala City Ophthalmics Association to give us this opportunity to be all of us together on this wonderful platform. The topic given to me today is management of neovascular age-related macular degeneration, optimizing anti-VEGF therapy through long-term fluid control. Let's see what we are learning in this era of anti-VEGFs, which is changing at a very rapid pace. And it is also telling us not to get good control of our patients, but also, giving them extended um, uh, anatomical and visual outcomes and stabilizing the retina over a period of time. Because it's a retina symposium, just a small disclaimer. What I have done is I have divided my talk in a couple of subheadings. First is what is an overview of neovascular AMD, what are the unmet needs in neovascular AMD, what do we really mean by fluid and what is the current understanding of fluid, what is Brolucizumab, what is the current understanding with Hawk and Harrier trial, and what is our real world experience with Brolucizumab, and in the end, a small summary. As we know, age-related macular degeneration is a leading cause of severe and irreversible vision loss worldwide, and it is going to affect more and more number of people. Neovascular AMD is characterized by fluid accumulation. This is a known fact, and if left untreated, results in severe and rapid vision loss. We are not behind the statistics from Caucasian population. The AMD is also one of the leading cause of blindness in India now, and we are at the threshold where more and more patients are requiring the treatment nowadays. There are two different aspects when we think about treatment for any different patient, any patient for us. One is unresolved fluid, and one is high injection burden for neovascular AMD patient. Now let's understand brief points. What I have taken from a lot of clinical trials is what is unresolved fluid. What we have seen is more than 50% of eyes had residual fluid after 2 years in real world patients. They receiving treat and extend regime with aflibercept, ranibizumab, or bevacizumab. We are not saying these molecules are bad, but this is the real world situation. The unresolved fluid is one of the major risk and the burden for us, as well as the high injection burden. Getting patients, especially in this post-COVID era, it's a big challenge. They're getting them every month to your OPD, seeing them, doing scans. So more than 50% of patients receive injection often than every 8 weeks at 1 year follow-up in real world studies. So this is a cause of concern. Why so? Because we need adherence to challenge for treatment, and also the non-adherence part which we have to take out. So this we have to understand. Now, if we look at the PAT survey done by ASRS member, that is American Society of Retina Specialists, which we were also part of it. In 2018, the survey told us that reduced treatment burden is one of the major risk factor in identifying treatment and monitoring burden as a key unmet need in neovascular AMD management. So reduced treatment burden is one of the factor which we have to encounter. Okay. Indeed, monitoring visits are the most time and resource consuming part of a patient care with anti-VEGF therapy for individuals with neovascular AMD. What happened in 2019 survey, similar survey was done by Vitreoretina Society of India as well. And that in that also we have realized that insufficient fluid resolution, that means insufficient resolution or suboptimal treatment outcome of anti-VEGF therapy for neovascular AMD is one of the major factor for clinical reasons to switch over between different anti-VEGF subgroups, whether it is Brolucizumab, whether it is aflibercept, ranibizumab, or bevacizumab, or a biosimilar. So this was one of the major challenge. Relevance of retinal fluid in neovascular age-related macular degeneration has changed over a period of time. And what we have understood is any fluid related to secondary to neovascular age-related macular degeneration is pathological, whether it is intraretinal involving the inner retina or outer retina, or it is subretinal, or it is sub-RP. The amount of fluid present, the duration of fluid present, everything has a role, and it damages the photoreceptors over a period of time, and also leads to kind of atrophic changes involving the retinal pigment epithelium. So involvement of fluid in current understanding at any level both in retina and subretinal level, all sub-RP level is considered as pathological if it is secondary to age-related macular degeneration. Now, if we look at the data from CAT trial, this trial told us that bevacizumab is one of the best molecules available. We all agree, because most of our patients, they need bevacizumab. We cannot just discard this bevacizumab out of our armamentarium. But it also told us a couple of other points. First, it told us about subretinal fluid, which was commonly seen in almost more than 80% of the population with choroidal neovascular membrane. The second most common was intraretinal fluid, and lastly, almost about half of the patient had a subretinal fluid, sub-RP fluid, sorry. So sub-RP fluid is also pathological, but it's seen in less number of patients. So fluid as a component of neovascular age-related macular degeneration disease activity was seen at almost all the levels. What is the clinical relevance? Now, we know fluid is pathological, fluid there, you have to treat it, but what is this role? Why you want to treat it? First is in diagnosis. As we said, OCT is one of the game changers, especially the Opta has changed the way we are managing this patient, that is OCT angiography, especially in the last 3 to 4 years, is one of the game changers for neovascular AMD management. Time to first treatment, the shorter is the time, the earlier we treat, the better is the visual outcome, both anatomical and functional. The disease activity, fluid is an indication of active disease, mandating further anti-VEGF therapy. Visual outcomes are directly related to the time of treatment and also the extent of the disease and so on. So the earlier we treat, the better out the outcomes. The stronger agent we use, the better out the outcomes. We all know that. And treatment interval, like durable therapies to control fluid and get better visual acuity gains and reduce treatment burden in these patients. In real world scenario, also fluid drives retreatment decision, especially in the presence of subretinal fluid and intraretinal fluid. Visual acuity loss was not a consistent trigger for retreatment. Okay, so presence of fluid is one of the major indication in real world scenario. If you look at the data from some more trials, absence of fluid, whether it is intraretinal or subretinal fluid, leads to better visual acuity outcome. This is what we know. More visual acuity gains is seen when there is a macula is dry, and anatomically it also functions well. So we have both the advantages of this. Increased fluctuation in fluid volume were associated with poorer visual outcomes by 24 months. So if I look at this data, where there is no fluid fluctuation, in the sense there is no volume of fluid which is fluctuating, like coming and going, coming and going. And if you look at the quartile data, quartile 1, quartile 2, quartile 3, and quartile 4, the most marked difference in visual acuity was seen for total fluid in eyes with most variability compared to eyes with least fluid variability. So whenever we have a least fluid variability, that means waxing and waning of disease, the visual acuity and the anatomical outcome is much better. In addition, eyes with most intraretinal and subretinal variability, as compared with eyes with intraretinal and subretinal fluid, the quartile functional is better. So this is a known fact even involving most of the major trials. And a consistent correlation between fluid and BCVA was identified in initial phases of treatment. This is what fluid study post-hoc analysis tell us, that the lesser is the fluid, the better out the outcomes. The correlation between fluid and BCVA was dependent on fluid type as well as distribution. So the more fluid is there in the right in the center of 1 millimeter zone, so the more poorer is the visual acuity. Now, what we understand with Brolucizumab and what it does to fluid in terms of a newer molecule, let's look at the anti-VEGF per se as a whole before we start talking about Brolucizumab. So this is something, a chain of antigen antibody, of an antigen and anti-VEGF looks like. The Brolucizumab is the most clinically advanced single chain antibody fragment, but how do they discover? So if you look at the structure of bevacizumab, this is the structure of bevacizumab. We have two Fab fragments and then we have a FC fragment. They are joined together. So the molecular size is bigger. That's why the penetration is less. But when we look at the ranibizumab model, this is a ranibizumab model in which only the upper portion was taken And then you have a CDR, they are complementary determining region. And when in Brolucizumab, what they have taken is 2 CDRs, and then they joined with a peptide range, which is these are like proprietary human SCF5 fold. And when they are joined together, the molecular size is much lesser, and the penetration is deeper, and also it stays in the contact with the desired area much longer. So this is where we are as compared to aflibercept, ranibizumab, bevacizumab, and brolucizumab. So this is what is the structural difference. In aflibercept, the peptide chain is on the top. But what happens as a staggering difference is this, that is relative number of molecules per injection present with aflibercept is only 1. Ranibizumab is only half. That doesn't mean these are inferior molecules. They have their own role to play, even in the era of neovascular AMD management. But if you look at the same thing for the brolucizumab, the availability of this drug goes to almost 12 to 13 molecules per injection. This is a very significant change. And also the size of the molecule is less, though the dose is higher, but this has been well tolerated and the efficacy has been well documented with this kind of dosage. Now, what they did in Hawk and Harrier trial, Hawk was done majority with US population and Japanese population. Harrier was for the European population. They did same thing what we have done in the past, and what we know the fact of aflibercept, that is give monthly loading dose, then space this injection over a period of time to almost 12 weeks rather than 8 weeks what we do in aflibercept. So you are having a treatment-free interval for almost 3 months. This is a big change. And they have also shifted this patient as and when required, suppose if there is a worsening. However, the most significant change came in the central subfoveal thickness and best corrected visual acuity, which has told us that it is much superior than aflibercept, both in Hawk and Harrier trial. If you look at this graph, over a period of 96 weeks, which is a very long period of time, which the data has been studied. And when we see this change, the visual acuity gain is much superior than aflibercept, as well as the central subfoveal thickness analysis. And this is one of the very important graphs which I found as quite interesting, is you see the fluctuation with aflibercept. I'm not saying it's an inferior molecule, it's a wonderful molecule. It still has its role to play. And we in last 3-4 years, I'm saying like we were using it a lot. But the fluctuations in fluid is much lesser, and the central subfoveal thickness is very well maintained with brolucizumab. So it tells us that brolucizumab has a superior drying effect and also superior functional outcome effect as compared to aflibercept in both Hawk and Harrier data. Does this translate to taking care of the intraretinal and subretinal fluid? Yes, it does translate to taking care of both the fluids, and also have been seen that consistently the effect have been seen and monitored at 16 weeks, 48 weeks, and 96 weeks. So it has a superior drying effect, and fewer patients had sub-RP fluid, which is one of the most pathognomic feature of choroidal neovascular membrane. The sub-RP fluid was very less in brolucizumab group as compared to aflibercept group in both Hawk and Harrier trials. Cumulative incidence of more than 3 consecutive fluid-free visits were up to 96 weeks, as you can see here. It was much more achieved with brolucizumab group rather than aflibercept group. So definitely there is a superiority of the molecule. The efficacy is there, superior drying effect, both and improving anatomical and functional outcome. And over 50% of brolucizumab 6 mg patient maintain dosing interval of Q12, that is every 3 months until for week 48. So this is also very exciting to know that this patient don't need monthly treatment. So this is one of the major outcome. And post-hoc analysis also told us in eyes with early persistent retinal fluid, numerically greater visual acuity gains were observed with brolucizumab compared to aflibercept. As what we can see here, it is almost 6.4 as compared to 3.7. So this is one of the major change and what we have understood, and also told us that higher proportion of these patients achieve BCV of more than 15 letters with brolucizumab compared to aflibercept. So early persistent retinal fluid, brolucizumab achieved superior greater CST reduction from baseline versus aflibercept. All this data, can it translate into clinical experience? That is what is a major challenge and major question. And what we learned from our colleagues from US, who have almost crossed more than 70,000 injections. And I think Brolucizumab in India is crossed close to is up to close to 2,000 injections, and it was available to us from October first week, if I'm not wrong. Whether in the US it was almost had its anniversary altogether. So we had a very good meeting on 27th with a few of our American counterparts, learning about the molecule and what is their experience and what is our experience. It's not of a big difference. What we have learned, we can start this therapy in both treatment naive as well as recalcitrant cases at one of the first choice. To share a couple of examples of my patients, definitely a thorough baseline workup for all these patients were done, including indirect ophthalmoscopy to be seen by the retina specialist, because now what has happened is anti-VEGF has become a panacea of treatment. So most of the time we are not even seeing our patient. Someone else is seeing the patient, you are injecting, or you are seeing the patient, someone else is injecting because of the treatment burden. But I made sure that Brolucizumab patients were seen by me personally, each and every patient, just to make sure that we don't encounter any adverse effect in the initial experience. So this was the first patient, 63-year-old male, occult CNVM treatment naive. As you can see here, he had a penetrating keratoplasty as well as retinal detachment surgery in past. However, the inner retinal contour was quite well maintained, and he had a very good outcome with a very thin epiretinal membrane here. But I thought let's minimize the number of interventions, because this patient already had lot many interventions in the past, and treated him with Brolucizumab. And within 2 weeks, what you see here is, such a good anatomical and functional outcome. The patient was very comfortable and happy with his visual outcome, and it is doing quite well. We have a recent OCTs of follow-up as well. We have not included due to lack of time. Another patient of mine, he was treated by me, before October 2020 of the availability of Brolucizumab with aflibercept. I'm not saying aflibercept is an inferior molecule. Most of these patients were on aflibercept, but the treatment response was slightly slow as compared to Brolucizumab. So this patient has a PED, though it's a notch PED. There was no component of idiopathic polypoidal choroidal vasculopathy. He had a EMD CNVM. And what you see here is a September 2020 scan. And this was post aflibercept, not much of a change. You see here pre and post. So it doesn't make the aflibercept as an inferior molecule, but the treatment response was slow. But this is again after one more aflibercept, the fluid here is a pre-RP fluid started coming off, and this was the time when I counseled the patient in November, and I said let's shift over to aflibercept. And this is what, Brolucizumab, and this is what happens after first injection of Brolucizumab in December. Such a good treatment response. You can see here the PED has significantly reduced with the drying up of the fluid in both sub-RP and sub-PED space, and also a very good anatomical and functional outcome. Over a period of time, after second Brolucizumab injection, the near normal contour of the retina was achieved. The PEDs are nicely flattening out, and retinal and choroidal contour is returning back to the normalcy. Another case has a occult CNVM treatment naive. One eye we already lost due to scarring due to CNVM in this patient. So he was under treatment by me, but the scarring was at a very rapid pace. We are not able to do much. But when he came for the first time, I said, no, let me start you with Brolucizumab itself. I don't want to, have a chance of you getting scarring in this eye. And what you can see here immediately post 2 weeks, we are following these patients every 2 weeks. One, to see adverse reaction, and the second most important point to see here is the response to the drug, as well as to our understanding. We need to improve as how the drug is working and what's happening, to the functional outcome of the retina as well. So as what you can see here, this is pre-treatment and post-treatment immediately very good response. After 1 month of Brolucizumab injection, though the CNVM was flattening quite nicely, we said, okay, let's give one more injection. And this patient is still on follow-up with us. So just to summarize, all fluid is pathological in neovascular AMD in current situation, and multiple studies have confirmed this, that dissolving fluid is key to achieving optimal BCV outcomes and longer retreatment intervals. Greater fluctuations in retinal fluid volumes. This is one of the key factors derived from all these trials. During the maintenance phase of any anti-VEGF treatment in neovascular AMD is associated with worse outcome at the end of 2 to 3 years. So we need to be careful about selecting these patients and also counseling them. And in both Hawk and Harrier trials, fewer patients on Brolucizumab had any kind of fluid at weeks 16, 48, and 96. So we are achieving a fluid-free interval. And sustained dryness of retina was achieved faster in Brolucizumab treated patients versus aflibercept, and hence fewer number of injections were required in those patients compared with aflibercept. So this is one of the major key take-home messages from all these trials, and also for our clinical practice. And patients with early persistent retinal fluid had numerically better BCV outcomes observed with Brolucizumab compared with aflibercept. So does this say that Brolucizumab, when it is available in your armamentarium, is the drug of choice for all patients? I will still say no. We have to be very, very vigilant in choosing our patients, counseling them, seeing them, try to look out for any kind of triggering factor which can cause intraocular inflammations and also on in post-injection period. So read all the fine prints very carefully, read test trials very, very carefully. Talk to your colleagues, and also let's collect more and more data. That's what we are trying to form a consortium group across India. Let's have more and more data from different regions so that we understand each other's experience and learn and give best possible treatment outcomes to our valuable patients. Thank you very much for a patient hearing, and thank you so much, Ambala Society, for giving me this wonderful opportunity. And we'll start seeing each other face to face quite soon, and looking forward to meeting you personally very eagerly. Thank you so very much once again.
Thank you very much, Dr. Manoj. It was an excellent talk. So we'll just move forward to our next speaker, and then we'll take over the questions for discussion.